and hopefully we can gain some valuable insight into the current state of the musculoskeletal system with COVID-19. So I called it Lockdown Lower Limb Legacy, and I think that that's really what we're going to be dealing with for a long time in the community and in primary care. Thinking about really the associated sports soft tissue injuries and the joint degenerative deterioration in the context of the environment we find ourselves in, and really what we should be aware of. So this is who I am. I'm a consultant in Addenbrooke's. I've been there now 8 years, and an associate lecturer in Cambridge University, and been in the military since '96. So I've been around a fair bit, and I've seen some interesting things in my time. This is really what you're probably aware of what I do in the majority. It's hip and knee replacements, as well as the trauma side, and more recently introduction of the robotic assisted surgeries, pelvis and the lower limb for the east of England, and as well as keyhole surgery for the knee and ankle, bit of biologics and cell therapy when it's appropriate and necessary, and then ankle surgery itself. So, you know, I was thinking about when I was asked to give this presentation this evening, I thought, well, what can I do that's really useful for you tonight in the next 45 to 50 minutes? And we've all been through this lockdown period of various degrees, and there's a heck of a lot of people who are either working from home or being furloughed. There's a lot of physical and mental deconditioning that has gone on, and not to mention marriage and family stresses of everybody not being out and about in routine daily life. With that, and with the advocacy of exercise and the rules and regulations that have allowed you to get out of the house, this has created what I'd call the perfect storm. So in effect, we have situations with Joe Wicks. We have lots of workouts that you can do at home. We have this impact loading exercise regimes, perhaps being performed by people who aren't ready to perform some of these activities in unsuitable footwear, maybe unsuitable floor coverings. And I've never seen as many people out road running, which is both good and bad. But with that comes problems, as you can expect. So across the spectrum, young to old, weekend warriors and triathlons and everything else, all this training regime that's gone on has introduced a fair amount of breaks and strains into my visualization of problems. So one of the problems with the lower limbs, I've talked about it, pelvic and lower limb surgeon, is that we all know that walking is man's best medicine. And we've known that for many, many centuries. And if you have a problem or a pain that's unrelenting in one of your lower limb weight-bearing joints, it affects everything in life. It affects it from the moment you put your foot on the floor, when you get out of bed until you get into bed that evening, by which stage it's probably hurting again and stopping you sleeping. So it is a real problem. And not only that, these conditions can be difficult to diagnose. They can have nuances. And then finally, often the treatment options are mismatched with patient expectations. So all of these come together to have suboptimal environment for patients. So here's a little list that I put down on my initial thought processes when I was writing this presentation. And this is both NHS and private patients that I've seen over the last 3 months of problems in this regard. And hopefully we'll address some of these tonight. And it's all conditions that you're aware of. You all know what these things are, but it's keeping them in your foreground of your mind, and a few pointers as to how best to deal with them. So it's all about correct diagnosis. Without diagnosis, then you don't know how best you're going to treat this problem and what the prognosis is. And in that regard, history and examination is everything. And as a secondary care surgeon, I have the luxury of X-rays on tap, as well as other scans, MRs, CTs, etc., etc. And I know that that is not readily available in the community and primary care setting. So I might be the one that gets to see a small percentage of these patients and end up talking about therapeutic regimes like platelet-rich plasma for tendons bursts or early osteoarthritis, or offering appropriate surgery in this current context with keyhole surgeries or tendon repairs, whatever, but that's not going to be really what you're interested in tonight. So back to the primary care and community environment, and this is the reality, is that generally you're dealing with an unhappy patient cohort at the moment who have, quite frankly, had enough of COVID-19 with the realistic prospects of another wave coming in the not too distant future. You have your difficulty in accessing diagnostics, and the problem of remote or video consultations and triaging patients over the telephone and trying to make a decision about who actually needs to be seen and examined and moved on appropriately. It's not a fun place that you find yourself in, and it's a difficult terrain to negotiate. So here we go. This is what everybody is aware of, the MSK treatment options and the non-operative environment. And really, you can't underestimate the initial sort of first three here with activity modification. The amount of people who injure themselves and won't stop that activity and think no pain, no gain is absolutely remarkable. And most of these soft tissue and even bony degenerative accelerations that we all see in our practices can be dealt with very easily by just laying off the exercise or the stimulus that's caused it for a period of time, and then gentle reintroduction. And many of them will benefit from routine consideration of weight loss as well as physical therapies. Medications, the good and the bad and the ugly. Well, you know, we all have patients who take non-steroidal anti-inflammatory drugs as if they're Smarties. And the benefits and the negativities of some of those situations. Chondro supplements, well, chondroitin, glucosamine, cod liver oil, they're really causing very little harm, as well as some new sort of complementary type medicine, turmeric, etc., which have quite well proven basis for joint and musculoskeletal problems. I want to talk to you a little bit about joint injections, and it's difficult in this environment to get shows of hands who uses a joint injection or soft tissue injection, because I realize we have a continuum of people that are watching and listening tonight. But there is some considerations in COVID-19 situation that you have to be aware of, as well as viscosupplementation. I use quite a lot of hyaluronic acid in my practice. Durolin, as well as other things like splints, braces, and acupuncture. So this is really what I wanted to just highlight to you, and I'm sure you're all aware, but when COVID-19 first reared its ugly head, there was significant concerns that corticosteroids might worsen the outcome in the context of a COVID-19 infection. So we all had our guidance, usually from the governing bodies, to suggest that we should stop delivering these drugs in this manner, which came with a huge burden for patients who actually derived a lot of pain relief and functional gain by these types of injections. So then as time progressed, we had trials, and it was the UK trial about dexamethasone, a drug that we're all aware of and has been around for a long, long time and effectively as cheap as chips. They welcomed the early results that would seem that dexamethasone is a very good thing in those who are severely ill with COVID-19. So the sort of restrictions began to ease a little. In that regard, eventually we have had recent guidance, and you may or may not be aware of this, but this is a really important document now that was released on the 16th of June, just gone. And for my own involvement, it involved the British Orthopaedic Association. So just to distill that document and not wanting to labour the point too much. So steroids in the appropriate patient are now relevant, okay? It specifically mentions that steroids shouldn't be given in this regard for MSK problems in patients who are shielding. Of course, you're going to have considered the usefulness and the need for that for the patient and explored and exhausted other treatment modalities and conservative management treatments. Appropriate consent. Now, when I use these injections intra-articular in soft tissue, I do specifically talk to the patient in this regard, literally the way I've said it tonight, and nobody has decided that they would defer that injection. There is an unquantifiable risk of an immunity dip and acquiring COVID-19 infection. These are all very grey zone statements, but it's quite useful to come up with something like that to say to the patient. I do use a smaller dose now than I used before. Some patient groups are sort of advocating maybe half the dose, but I use slightly more than the half in my practice, because if you don't use enough, it's maybe a pointless thing to do. But consider using a reduced dose. And just to make you aware, one-off steroid injection for local action will not put someone into a shielding group. So you don't have to specifically tell them it's got significant restrictions on their lifestyle. So we can revisit that if you want to later on, but it is important in the current context. So some of those lists of conditions then I want to just spend a few minutes thinking about. So pelvic considerations, it's extremely important because the pelvis is obviously the gateway from the axial skeleton down into the weight-bearing lower limb. And as a pelvic surgeon, it's very interesting to consider and understand the various parts of that bony anatomy. I just wanted to briefly mention about osteitis pubis or pubis symphysitis, and this is something that I've seen more of in the younger populations with these repetitive impact type actions. And it's really a situation to be aware of because it's very difficult to treat. And if patients don't lay off the activity and really have a little bit of a hard sell by their therapist and their clinician, then they may well be making things much worse for themselves. And it does take patience. It can take 3 to 6 months for these young footballers or impact loading, stork leg sort of transfer with lots of movement at the front of the pelvis through the symphysis to settle down. So ironically, you can place ice over the front of the pelvis in this regard, and the use of anti-inflammatories with all the usual sort of advice that goes with that. And then you move into the more invasive territories, and I wouldn't suggest that this happens in primary care or the community in this regard. Some patients have benefited from some wearing tight sort of lycra type pants almost to try and give the pelvic girdle a bit more stability as they're going about their normal activities, and then gently reintroducing exercise later. Surgery with resection or fusion is fraught with complications and a very guarded success sort of story. So you really want to try and avoid that if you can. So there's a whole conglomerate now of conditions around the proximal femur and the hip joint itself, and they've distilled into single entities and then have been brought back into a sort of a generic syndrome again called trochanteric pain syndrome. And it's very common, I'm sure, that you see patients in this regard. I've highlighted a few of the single entities, which are really quite easy for me to define with imaging, such as an MRI scan. If you're considering about the trochanteric bursa on the side of the hip, this is something that can be dealt with really quite nicely with activity modification, but largely usually by some soft tissue steroid administration to the area of the maximal tenderness. Which will allow the patient after a period of rest to hopefully break that inflammatory cycle. If it's intractable and they keep coming back for more, don't keep injecting steroid in that same area, because you are going to have a problem with rupture of the soft tissues or some sort of lipid sort of dystrophy or other problems like that. It is probable that they have got more going on than just a trochanteric bursitis, such as gluteus medius or minimus tendinosus, and particularly in the sort of athletic population and those that have reintroduced running back into their sort of daily regime. And I've got a couple of, I don't know how well this projects across onto your screen, but you can see on the MRI scan, the central picture here shows a trochanteric bursa lighting up like a beacon with florid trochanteric bursitis, and that's very amenable to injection and being dealt with in primary care or community. Whereas when you have problems with the gluteus minimus and medius tendinosis coming through, then these injections need to be targeted down into that area for maximal benefit and effect. So that's just something to think about. And of course, surgery, which is rare, is always there in the background for intractable problems. Piriformis syndrome took a real sort of upturn about 4 or 5 years ago. In fact, it wasn't even really known as a single entity when I was training, but I've picked this MRI scan off the internet because it's the best one I've ever seen in terms of the piriformis muscle being edematous and really lighting up like a beacon. The majority of piriformis syndrome, in fact, some people even question whether it's a true problem. But again, as a pelvic surgeon, I can tell you that the piriformis comes in various different guises and directions, and some are very bulky and fat and entrap or encapsulate the sciatic nerve, and others is hardly there at all. And it is the ones that are causing an impingement phenomenon, as if the sciatic nerve comes out of the sciatic notch just down here, that can cause impingement because it's got less room for movement. They used to talk about gentlemen with a wallet in their back pocket and sitting on that repetitively. Again, you can imagine how you could have some soft tissue entrapment or impingement with the sciatic nerve behind the ischium here. Different activities that cause the piriformis to become hypertrophy and well developed, obviously in appropriate exercises or weights or squatting and that sort of thing. Lots of downhill running, kicking exercises. So sometimes footballers or rugby players with the lead foot, or even sitting in hard surfaces like I just mentioned. Warm-up exercises, it is probably just so to loosen everything up and for to not run off cold. And again, really when you're dealing with this, and I find when I find a patient who has likely piriformis syndrome that's not amenable to the conservative management and exercise profiles that you can see pictures of, then I ask for diagnostic injections. You don't want to be sticking a needle anywhere near blindly where the sciatic nerve is. I've only ever had to decompress one of these, and again, that's as a pelvic surgeon with lots of plating of acetabulum. So again, that's a rare phenomenon. ITB friction syndrome. So again, that can happen at the top over the trochanteric bursa, or if the ITB, which is implicated in lots of runners' problems, can be sore at the bottom, just at the lateral aspect of the knee before the ITB inserts onto Gerdy's tubercle. Again, risk factors include a sort of a native sort of tight tendency to the ITB itself in a well-developed muscular individual, running on sloped surfaces where you're continually stressing and causing a friction type interface, and then inappropriate running footwear. And you can look at shoes and see if there's a lot of lateral wear on the actual sole, which could indicate this. So the mainstay of treatment of this is with physical therapies and stretching and massage. Of course, injections can help alleviate the sort of acute syndrome profile that you can see, but often it is change in behavior and addressing these factors that really makes a big difference, and hence they are self-limiting in the majority. I thought I'd touch on meniscal knee injuries because this is something I see in most clinics, to be honest with you. It's 10 a penny, and I think that meniscal knee injuries are really quite interesting because we probably all have a torn meniscus after a certain age in our life, or even having played sport or been particularly active, and it's trying to work out which are the ones that brings patients to your doorstep, and how comes we're not all hobbling around and being non-functional. And I think when you get a significant acute injury to the meniscus, particularly the ones that come into the joint, then those are the ones that pull on the actual capsule. So I always tell my patients that effectively the meniscus is a fibrocartilage type structure, and as you get older it is stiffer and a more fibrotic structure, and it's more prone to injury. And a lot of these squatting activities and twisting and torquing through the knee are actually entrapping the meniscus and twisting it and pulling it. In the younger individual, the structure is more resilient to this type of force and it's not a problem. But of course, as we get older, or if you just catch it in the wrong way and you tear it, then that's the start of the problem. So how can a structure that's effectively aneural cause so much trouble? Well, where these menisci are attached to the capsule of the knee joint itself, they're richly innervated. And that's when, if you get tugging on that, that's when the patients get the sharp intake of breath and that feeling of instability. And some patients even fall because their knee just gives way and lets them down without them having any protective mechanism. The picture shows lots of different types of tears itself, and the bottom one is a bucket handle tear where you've got a complete tear which is in continuity with the remainder of the anterior and posterior horn, but it can get trapped in the notch and be a limiting flexion and full extension. So it's quite interesting. MRI scans are very interesting. You know, if I MRI scan both my knees, I will have degenerative menisci for sure. I'll have fluid signal in the meniscus itself, which you can see here on the AP projection. The difference being when you look at the sagittal projection, that you have that degenerative fluid signal which tracks to the surface, either in the superior or the inferior aspect of the joint, indicating it's a tear. And you can work through the sequences. So MRI scan is very useful for the diagnosis. And of course, you can see the acute changes that goes on with that. I put a little bit in just for your interest. By the time patients come to see me, then what I'm concerned about is getting a diagnosis and then concerned about how best to treat these lesions. Now, if you talk about a youngster who's either played sport or had a discrete injury, they may well benefit from considering a repair of that meniscus if it's suitable. Now, suitability is very interesting because it does depend on the acuteness of the injury. So we have this dichotomy of a problem whereby most menisci don't come to a surgeon like myself within a very short period of time. Most go through MSK pathways whereby we know a large number will settle or become less symptomatic with physiotherapy in time. So I only see usually the symptomatic lesions. Now the problem with that is that with time and ignoring this injury profile, then the edges get rolled, becomes more fibrotic, and becomes less able to have a suitable repair for the youngsters. So I would encourage you, if you have a young person who you think has had a significant knee injury, with possibly a meniscal tear with McMurray's, although that's a very subjective test in the light of an acute knee injury. I think that if a young patient has, florid joint line tenderness, either medial or lateral, who are displaying mechanical symptoms within the knee, or particularly any blocked or full range of movement, they should be referred for consideration of a scan, because you may find that a repairable lesion has become non-repairable. That being said, only the 25% roughly of the meniscus is vascularized, the periphery where it's attached to the capsule. So that gives you a zone whereby you would hopefully affect a successful repair. But even in a young person with appropriate good repair itself, with the use of a brace up to 3 months after the injury, limiting deep flexion, only 75% of those actually heal. So it's not a great subject to talk to patients about. And the majority of these lesions, for appropriate reasons, get partial meniscectomies. And that simply means where you go in and you take the tear away, leaving the peripheral rim. So usually 30–40% of the meniscus, the increased depth of the meniscus is left. So there's very little detrimental long-term problems with taking a small amount of the meniscus away. I also talk to my patients about having like a window wiper inside there. So if I get patients who are left too long and the joint was fairly good beforehand, you have a meniscal flap that is continually swiping in and out of the joint, causing an abrasion to the subjacent cartilage, then again, that's not a great thing to have. Okay, enough about menisci, but hopefully that gives you a little flavor of why these injuries are common and why they're important to consider which sort of category you're going to think of them in. Tendinopathies are a real problem because, again, this is a real hotbed of impact, repetitive impact, hard floor type regime. And I've seen quite a lot of Achilles tendinopathy as well as jumper's knee. You can see the MRI scan of the jumper's knee just here. So a massive amount of fluid signal in the superior aspect of the patella tendon. And I'm going to come back and talk to you a little bit about Achilles tendons again later on, because they're really important, because it's a high-risk strategy not seeing these type of patients who phone in for their consult with a GP saying that their Achilles tendon is swollen and sore, because there is an increase in missed injuries and an increase in subsequent litigation. Pre-COVID, never mind the sort of environment that we find ourselves in. I mean, everybody, barn door Achilles tendon rupture is fairly dramatic. The patients tell you that they've been kicked in the back of the leg. Some can even hear the audible snap, and then the unit doesn't work anymore. Risk factors to be mindful of: smoking, steroid use, as well as ciprofloxacin has been implicated, and obviously older patients and inappropriate exercise regimes. Just moving down the leg and keeping sort of the sporting theme. Medial tibial stress syndrome is probably something that we underdiagnose, and most of it is just leg pain. It never comes to the environment of you know, a primary care community. But you can have anterior tibial stress syndrome, again named for the shin splints, or even posterior. And this is basically periostitis, where the muscles, as they insert onto the periosteum and bone, are repetitively tugged and can cause little flap elevations and inflammation. They're very much more common in females, and the risk factor is those with significant varus or valgus knees, tibial torsion, which you can see from just looking at the patient, or excessive femoral anteversion, which again is slightly more difficult for to appreciate by just looking. Foot arch abnormalities, flat feet or high arches can implicate the way that the muscles pull on the leg itself, on the tibia, any leg length inequality that's significant can cause increased incidence of this. Again, it's quite easy when you get an MRI scan. You can see the MRI picture that I've included at the top, which clearly shows a periostitis with a fluid in the regions that are anterior with the tibia. A lot of these, again, the vast majority settle down and probably never come across my doorstep in terms of rest, non-steroidals, physical therapies with stretching. Thinking about, is there something that's causing this a background problem? As we've mentioned, the risk factors, appropriate footwear and orthotics. Rarely do you have to administer a pinpoint injection to try and settle something down. Shockwave therapy, which I don't do, has been advocated as a very useful resource. And in 2 patients, I've had to perform fasciotomies because there's a continuum of shin splints into sort of chronic compartment syndrome type sequelae in athletes and military personnel, but that's very rare. So this bone stress response is very interesting, because every time we walk across the floor, we have little micro cracks and propagations in our living bone structure. And we've got 2 main cell populations: our osteoclasts break down bone, and blasts make bone. And if we have a situation whereby we've affected the bone homeostasis, in other words, the clasts and the blasts are out of sync, or cannot keep up with the demand that's been placed on them, then the bone will become weakened. And before it becomes weakened, you can actually physically see on MRI scan bone edema. So swelling within the bone, which is actually a very painful pressure increased phenomena at that time. So bone stress response syndrome is a continuum, and if that's left unchecked, and again, it's particularly common in road running. So someone who's gone couch to 5K without the couch bit, and has just been used to being on the couch, and they try and overdo it, and they just won't let it settle, then those micro cracks will coalesce and can form the stress fracture. So that scan on the left shows a proximal tibial fracture, and the bottom one on the right is a distal tibial plafond type fracture. And these need to be treated as fractures, because that's exactly what they are. So you need to immobilize the joint and deal with them appropriately. Most of them, the vast majority, are caught at the bone stress response, because it's actually very painful and are completely a self-limiting problem if the right advice is given. Ankle injuries, well, there's so much going on around the ankle, it's very easy to injure it. And I think that every single one of us listening tonight have had repetitive ankle injuries, whether it's just sport related or even non-sporting type through life. Inversion injuries are extremely common, and then that causes little micro problems both within the joint and in the soft tissues. So I have seen an increase in ankle problems as well as the tendinopathies around that. But the Achilles tendon, again, is something that you really need to be aware of. We've talked briefly about the risk factors, but I just wanted to show you that if you don't see these patients, you won't see the early signs of the fusiform swelling and the tenderness along the stretch of the tendon that's weakening. So I'm not talking about the tendon now that snaps when the patient's been stumbled when they're out running or playing football or what have you. I'm talking about the tendons that actually are declaring their unhappiness for usually quite a long time with Achilles tendinopathy before weakening, and then becoming the integrity of the structure is not such that it's good and will rupture with the right stresses put across it. And, you know, we might all have, I've certainly had Achilles tendonitis in the past, and it is really painful, and it does limit you in what you can do. And the majority, again, are self-limiting with appropriate rest, stretching, eccentric exercise protocols, all these sorts of things. But if you do miss a rupture that has slowly pulled out with time, then you can be in trouble, because a chronic tendon rupture is a very different kettle of fish than something that is fresh. The interesting thing in orthopedics is that over the last couple of years, we have been more and more introducing conservative management to the majority of these type of injuries. So the young sports person who can't actually buy the thought of them having a reasonable result at a year by not operating on them tend to want a good result at a year by bringing the tendon ends together, with the risks that go with that, such as infection or clots or re-rupture. So the way I just basically, in a very sort of black and white manner, the literature would suggest that if you repair an Achilles tendon, then you have a slightly decreased chance of re-rupture into the future. But actually your functional outcome is almost equivocal at a year's point. Your power is probably not quite as good. But again, the majority of us are not athletes, and we would have a very functional outcome without any of the surgical risk. So probably for about 80%, maybe even a little bit more of my Achilles tendon ruptures, they get treated with a walking boot and Aquinas cast and my accelerated functional rehab, which is still a huge hassle factor. It's still 3 months of their life in some form of immobilization and getting going with their physical therapies thereafter. And realistically, for the sports person, they're probably only getting back to those type of activities about 6 months or so later on. Now, if they need surgery, then I use a percutaneous type approach, which is fairly atraumatic and brings the tendon ends together. Then I put them into the accelerated protocol in a slightly slower fashion. Now, the old style used to be horrendous surgery. You know, I remember the days when the back of legs were flayed open and the operations looked like this. But if you miss a tendon rupture, probably within somewhere between 4 to 6 weeks, then you cannot do an operation like this anymore. You're more condemned to either a bigger open operation, or certainly if the tendon ends are so far separated that you can't bring them together again, and that's probably after as short as 2 months, then you're condemning someone to something like an FHL reconstruction, which has significant loss of power to the big toe flexion, and the end results are nowhere near as good. So just a word of caution, these are the type of patients that I probably would suggest that you bring into your practices for clinical assessment and referral on as needs be. Plantar fasciitis, now this is a painful condition. And again, it's repetitive on a hard surface. We used to think that when we did an X-ray, the plantar spur was something that was related to calcification of the ligament insertion, but I don't think it is. And I think the literature would support that this is just something that is a finding that goes along with it. But pinpoint, really tender sort of heel, usually on the medial aspect, although it can be on the lateral as the two bands of the plantar fascia insert, can be a real intractable problem. So again, it is important that the patient actually stops early and starts employing this conservative management modality of stretching, rolling exercises. The literature suggests about cold Coke cans that you can roll along the heel and the foot, trying to stretch that plantar fascia and to break down the vicious cycle of the inflammatory cascade that's going on. I only see these ones when they obviously come to my practice where the conservative management hasn't worked, and the vast majority of them in my hand then settle down with steroid injections. The risks, I guess, are plantar rupture and the need for further injection. I'll happily inject twice. I'll think about the third. It's rare that I have to do 3, but I won't do any more. So plantar fascia rupture is quite a big problem to deal with. And of course the surgery, which I've only done one of in my lifetime because the vast majority don't need it, is surgical debridement or partial release of the fascial band itself. Obviously congenital problems and foot arches can be implicated in this problem. So plantar fasciitis is something that you can really help patients out with very nicely indeed. And there's a lot of online literature and information for patients. And Morton's neuroma, again, there has been an upsurge in that, in that's come through to my sort of clinics. Have a little look at the MRI scan that I put in at the bottom. So there's an overlap of bursa problems between the metatarsal heads and the neuroma. So you can just see the neuroma at the bottom here on the right. And this is why patients talk about walking on a pebble. They feel as if they've got no pad on their foot, and it is really debilitating. It's very common in the second third, or the third, fourth web space. They talk about Muller's click by side compression of the metatarsals. Again, if you have appropriate footwear, cushioning, and sensible modification of activity, these will often settle down, but it can take a very long time. And I can tell from personal experience that I have a Morton's neuroma in my left foot, which was rather debilitating, probably for maybe 3 months. And I tried to gently run through it, and I kept having to ease up on that. But after a year and a half, I still have it, but it's manageable and it's not a problem. I've not had it injected or anything like that, but they do respond fairly well to a steroid injection, which can help shrink the nerve bundle, the sort of ball of excitable nerves as it divides to supply the both sides of the toe. Can settle that down nicely, and I've only excised 2 in my lifetime for the ones that just won't settle. So again, it's very important, very debilitating foot problem, which can actually be greatly influenced by understanding it and helping the patient understand it as well. I just mentioned some of the adolescent stuff on my list. The 2 things that cropped into my mind were really apophysitis type problems. And the first one is Osgood-Schlatter's disease. And in the last month, I've seen 2 kids that have reintroduced previous sort of running and training, sort of change in direction and jumping type phenomena. And this is where you have inflammation of the patella tendon as it inserts onto the apophysis of the tibial tubercle on the proximal tibia. And we all have, growing up with friends and that sort of thing who suffered from Osgood-Schlatter's, and they can have quite significant elevation of the tibial tubercle and fragmentation at that time. It's very rare to have loss of the extensor mechanism, to have a complete pull-off, but I've certainly seen that in my time. And it's important that really these children understand what's going on and then have appropriate decrease in these type of activities so they don't have any permanent lasting problems. And again, 95% of this is all self-limiting problems, but the amount of ladies that have quite excessive bumps on their tibial tubercles from having Osgood-Schlatter's as a adolescent, and now have problems kneeling because of that, it's not insignificant. So it's an important thing to be aware of. Again, nothing that's nasty, but will influence their outcome. And down the other end of the spectrum, down in the foot, is the apophyseal of the Achilles tendon that we're talking about, and the calcaneus, so Sever's disease. And that's again in active children, that are, particularly as they're growing, so the tendon unit hasn't grown fast enough, so they are tight in their Achilles tendon. And with that, you have a traction type injury to the apophysis, which is rather painful. So you can put ice on this and you can slow the child down. Anti-inflammatories are quite useful. And then this is a very simple thing, but if they have a softened heel cup and a little shoe raise with that, in terms of the device itself, the orthosis, that shortens the Achilles tendon and actually takes some of the pressure off the apophysis and can help that child through the next few months, as it is a self-limiting condition as well. Okay, I have mentioned PRP at the very start, and I think that this is a rather sort of controversial subject, and it's also one that's not very well understood in terms of the actual mechanism of action. But what we do know is that there does seem to be a definite benefit in this biological treatment without any of the sort of negative potentials of steroids and other synthetic drugs that are administered. And really, it's found its use predominantly for tendinopathies. It started around the elbow for tennis and golfer's elbow, but has been shown to be very effective. And I certainly have some Cambridge rugby and players that have benefited from their jumper's knee and their Achilles tendinopathy as well. The problem with the Achilles tendon is that as it gets inflamed, it eventually brings microvasculature to that area to try and bring a blood supply to heal the tendon, and with that comes the nerve fibers, and that's why you can get into this intractable, painful sort of Achilles tendinopathy type environment. So PRP effectively is your activated platelets. So when you have an injury, you bleed to that area to affect and to start the inflammatory cascade, and platelets activate all these drugs, all these tissue factors and growth factors that are implicated in the healing and regeneration pathways. So it's no wonder why we don't really fully understand this. And of course, everybody's blood's different: females, males, menstrual cycle, smokers, steroids, all these things play into your mix of who you are. But effectively, you can take 60 mils of the patient's blood, spin it down, and it's a buffy coat the platelets and the white blood cells, which are the therapeutic regime, which can be delivered appropriately to the various different things that I've talked about. Just going to touch on arthritis, because this is a very difficult time for lots of patients with COVID-19. We all know what osteoarthritis is. It's effectively like your car tires wearing out. It's wear of the cartilage with time. Under 45 years, males predominant, and greater than 45 years is more common in women. This is your treatment, or my treatment triangle, which hasn't really changed much in my time of practicing. But this is the bit where you can make the most difference. So right at the bottom, where it's patient education, weight loss, physical therapies, and devices to help with them. And then you really, after that, climb in the analgesic ladder to eventually they come and meet a surgeon like myself that has to replace that joint because there's no other option. So what we do know from the literature is that the optimal time for arthroplasty is very patient dependent. In other words, there's not one size fits all. And we certainly know that patients can wait as little as a year before they feel at their end stage. And there's those that will wait almost their lifetime before they have anything done. But the international guidelines suggest that everybody should have non-pharmacological treatment as a start off with physical therapies and patient education with exercise, and really keeping the strength, keeping the muscle mass and the proprioceptive components of the joint are extremely important, as well as not allowing the joints to stiffen excessively. What we do know is that you can influence and impact on reducing the arthritis-associated disability, and even that comes along to mental health and physical well-being during the time of not needing a significant operation like an arthroplasty, but the years before that. The literature, if you look at it, these are factors that would suggest that they do better. So if you've got one hip that's hurting rather than two, if you're on the slightly younger spectrum, so that's less than 58 years, and if you've got a significant pain, so that's over 6 on the analog scale, and symptoms less than a year. In other words, a short acute problem, if you can get in there early, you're probably going to actually affect some change. And I think that the vast majority would suggest a 6-week program of physical therapies. And really what you're trying to do is instigate behavioral changes, affect exercise modification and BMI and sort of outlook on life that will keep them going as long as they can. There's a lot of work now about PRP as well in early arthritis. Don't believe anybody that says that PRP is going to resurface your cartilage that's gone. That just doesn't happen. And I think the way I explain it to patients is that PRP probably more modulates your pain response on the pain fibers and mopping up the cytokines that are a byproduct of osteoarthritis to allow you to physically be able to move that joint in a more pain-free manner, which then benefits the physical therapies and hopefully keeps you away from the joint replacement for as long as possible. And then this can be used in the hip, the knee, and the ankle. And indeed, although it was seen only for, excuse me, I'm going to have some water, a private practice mainly, there are trusts, NHS trusts, that have approved PRP and osteoarthritic preparations in this regard. I think really what you're looking at is health rationing. whereby, if everybody that had arthritis had a PRP injection, that would be a huge financial burden on the health resources. So watch this space for the future. These are the other substances. I mean, hyaluronic acid isn't particularly cheap either, I have to say, but steroids, cheapest chips, and probably only dampen down the pain response and do very little else. In fact, I do have my own concerns about the base that steroids are in. It's a granular delivery mode that never disappears. And when I do a joint replacement or open up an ankle at keyhole surgery and it's been injected, you always see the white base of the steroid preparation. And it's interesting. And there's some early evidence suggesting that those that have had a steroid injection may well accelerate their arthritic profile after a short period of benefit. Now, you can't unravel that to suggest that it's actually the steroid that's doing the damage, or whether it's an increase in patient function and ability and living life that actually accelerates it. In other words, it wears quicker because they're doing more. But it's a school of thought to bear in mind. There's lots of literature. This is an interesting RCT that I looked at, and really they suggested that PRP injections is probably more beneficial in terms of treating knee osteoarthritis at 3, 6, and 12 months follow-up compared with everything else, including placebo, hyaluronic acid, putting ozone in there, and steroids. So there's a lot of information that will come out with time. So going back to COVID-19 and where we sit here in the UK and in our own little bubble in the east of England in Addenbrooke's, and if you come to me and you've got cancer and you need me to do something very fancy with you, or an older person with a broken acetabulum, that's still going to be happening under my care. Or if you're a polytrauma patient, then you're going to get fixed. This is a prostate cancer patient who I fixed only yesterday. So they've got significant acetabular erosion, and they've had what we call a Harrington plus in that regard with the risks of COVID-19. A trauma patient who comes in with a fractured neck of femur as well as open fractures to the legs. It's a real mess. They still get fixed up under my care. But what happens if you're this 68-year-old patient who was in my clinic in February, just before COVID, and was booked for a joint replacement, who can barely walk and is in severe pain? Well, the bad news is that there's no elective arthroplasty and in Addenbrooke's as yet, but despite efforts, and there's only small amounts of arthroplasty happening up and down the land, which is why you have all the well, it's not scaremongering, it's reality, but every paper in the BBC reporting that the NHS overall waiting list could be 10 million by this year, and orthopedics is going to be a significant part of that, because by and large it's not cancer and it's quality of life. So it is real. It's a real problem, and I am seeing more patients coming through and reverting to private practice for what you may think of that, good or bad. But private practice is slowly coming back online within COVID-19 guidelines. I am seeing lots of distressed patients, and I can tell you there's going to be a huge burden of care looming both for the NHS and private care, probably for the next year or two, and we may even spend the next 5 years trying to get past this this problem that we're living in now and in this day and age. So hips and knees, in terms of my private practice, I perform all the stuff that I do in Addenbrooke's, but there's other options, and this is where patients who are suitable feel that they're getting more bang for their buck in terms of having to pay for the treatment with custom-made prostheses, both for the hip or knee, or even robotic-assisted surgeries. This is a type of planning that goes into my custom-made type approach. This is a Symbiosis hip in a 26-year-old gentleman who's got bilateral perthes and who's had his life given back to him with his custom hip on the right side. Again, this is a conformist 3D printed knee replacement that comes across from the US when I send all the relevant data of the patients, and my patients are doing very well in that regard. You may be aware of robotic-assisted surgeries. It's certainly here in Cambridge, and I think that's for a very good reason, because it is the future, and the tagline is no more, cut less. And it's all about having a greater understanding of the joint anatomy, because we're all different before you actually start the surgery, having had a solid plan in place, and then the robot merely acts as a sat-nav when you're in theatre to effectively help you execute your preoperative plan very accurately. So that's what the robot looks like. It's for £1 million. It's not very exciting. It looks more like a few arms on a cornflake box, but it's actually a good bit of kit. And you can use it for hips, knees, and partial knees. I'll have a slide very shortly about my website whereby you can look on there on the blogs. It's quite a useful patient resource for all the type of problems that we've been talked about, particularly even the robotic surgery type of thing, and pros and cons in a very open and honest and black and white fashion. So there's a reasonable amount of information there on carrothersorthopedics.co.uk. So it's a powerful adjunct for knee surgery. You get pretty horrendous medial unicompartmental knee replacement territory type patient. Careful planning allows you to have some very pretty x-rays, which the patients benefit from directly in terms of faster recovery and better kinematics within the knee. The total knees are the same, as well as hips. So the virtual hip, this is the way I've planned the operation, the virtual x-ray on the left, and then what I executed on the right. Helping patients along. So really it's what's all the fuss about? It's, well, why wouldn't you use the latest technology in a safe manner? They're not, there's no guinea pig material. It's effectively using, tried and tested implants to be put in to the best of your ability. So it's not all about what I say about this stuff, but if you look on my profile on iwantgreatcare.org, you can read through 328 patients, a lot of whom have had either trauma surgery or cancer surgery or arthroplasty, hips or knees, and have been very, very kind in their thoughts on that. So I send my patients to the website to have a look and see what patients say, because I think that's much more powerful, rather than hearing what the surgeon specifically advocates in terms of latest technology. So the website hopefully will be something that you find beneficial. The blogs, as you can see, I've just put up this random section, so it's not all about hips and knees, it's to do with sports, vitamin D, I'm doing series on COVID, etc., etc. Online simple referral, so one sheet, or even just send an email to inquiries@Carrothers Orthopedics. Carol, my secretary, is wonderful. She makes things happen fairly efficiently and easily for patients. So I think that I've said enough. My voice is about to give up now, and I actually don't have the time. I don't get 6 minutes. That's not too bad. I'll leave the information up on how you can contact me or look at the social media platforms as well. And Harry, I don't know if you want to moderate a few questions, or if anybody just wants to zoom off and enjoy the rest of their evening. But hopefully that was useful for everyone.
That's fantastic. Thanks, Mr. Carrothers. I'm just having a look. We haven't got anything in the chat yet, but yeah, if anyone feel free to put a comment in the chat if you have any questions, or simply unmute yourself, whatever's easiest.
Sorry, can I ask something? Hello?
Yeah.
Yeah, hi. Just wanted to know, do you still have precautions after hip replacement, like 6 weeks, no crossing legs?
Yeah, so I don't use hip precautions anymore. I try and engage and explain to my patients it's about being sensible. So I tell them that it's really important in the first 3 months, to be honest, but the first 6 weeks are crucial that they don't have a hip dislocation. I also tell them that the way I've put it in, I know that it's not a sloppy joint. In other words, they are not at increased risk of dislocation as long as they don't do anything excessive. And one of the worries is that as they build their confidence is that they fall or twist, so having a inadvertent trauma to the joint. But again, hip precautions aren't going to improve that situation if that's what happens. So 90-90 isn't necessary. The literature suggests that we shouldn't be binding people to high toilet seats and high chairs and that sort of thing. If the arthroplasty is performed appropriately and the patient acts and understands what the expectations are, they'll find their own way.
Okay, thank you.
I've just seen a couple of questions come up. So from Kevin, mini hip resurfacing versus traditional hip replacement. Grateful for your thoughts.
Yeah, so I mean, I think that without having a patient, it's very difficult to have an answer, because that's why I have a fairly large range of options and appropriate non-guinea pig material in my armamentarium. So when you see the patient, you then have a tailored discussion about what's more appropriate. So mini hips resurfacing, you know, the problem with metal and metal is a real problem, and I think that I would struggle. So I don't do metal on metal because I spent a lot of my time as a young consultant writing papers about the problems with metal on metal and revising metal on metal. If you have a very good functioning metal on metal hip resurfacing or mini hip, then you're going to probably get away with it, and you have a very satisfactory outcome, which is why I was quite surprised to see Andy Murray in that environment, and the conversations I had with every patient after that scenario. When metal on metal goes wrong, and you don't know usually for the first 10 years plus, then you have a problem and you can't go back from that. So to answer your question, I'd steer away from metal on metal, that's for sure. The bearing surfaces now are very good, and hard and soft for the majority of people. So a ceramic femoral head on high-grade cross-linked polyethylene is a very forgiving surface, and for the younger patients you can consider a ceramic on ceramic articulation, with the very small risks of either squeaking, which might be fun for the first month but it's not after that, or fracture if they have a high impact injury. But fracture of ceramic bearings are much less of a problem now as it was maybe 10 years ago. I have lots of conversations about approaches, so mini posterior, mini implants, posterior lateral approaches, anterior approaches. These are all very flavorable things to talk and to discuss about the patients. In fact, I was on the BBC Look East probably 2 years ago with direct anterior approach surgery and the benefits of that. But every patient is different. Every patient comes with a different set of goals, expectations, BMI status, aspirations about what they need to do. So it's a tailored conversation. I hope that answers your question.
Brilliant, thank you. And there's one more. Should the McMurray's test be done to diagnose a meniscal tear, or should it be avoided as it can cause further damage?
So I think that, someone who's got an acute knee injury is not going to allow you to do a McMurray's test first up. So it is unlikely that by performing a McMurray's test that you think you're performing, that you're exacerbating the tear. So the whole idea of McMurray's test is that you're actually trapping the fragment in the joint and tweaking it through the capsule the way I've described it. So it is not an aggressive maneuver. All you're looking for is that sort of initial response on the patient's face. And a lot of patients won't even let you get to that stage because they know their knee's sore. So a joint line tenderness in the right locations with the right history is everything, particularly since that patient in my setting is going to get an MRI scan anyway. So yeah, I'd say be careful. And obviously if you lose the confidence of the patient early on, then it's game over. I think you must all be tired tonight. I don't blame you.
Brilliant. There are a couple more.
It's very difficult because obviously in a proper room you'd sort of get that feedback and you'd see who wants to talk and who doesn't and sort of. But at the moment I'm just talking to myself.
So this one's from Philip. Do 20% of the population have their sciatic nerve run through their piriformis, as I've been told to your knowledge, influencing piriformis syndrome, and are unicompartmental knee replacements available at Addenbrooke's? Also, is there an age cutoff for regarding MRI for knee pain patients, regarding patients with no concern of sinister pathology and primary?
Right, stop. Okay, I can remember the first two and then you can go for the third one. So the first one was about piriformis. Yes, the anatomical variations is huge. If you look at an anatomy textbook, you can roughly divide them into those that split through piriformis, which is roughly 20%. But of course, there's probably about another 4 or 5 variants that I've seen in my lifetime. and those that predominantly come out above the nerve. So it's huge variation. So yes, I buy into the problem that there can be with the impingement or the entrapment. So yes, anatomical variation. The second question was regarding unis and Addenbrooke's. Yes, there are unicompartmental knee replacements. It tends to be the Oxford unicompartmental knee replacement, which is a tried and tested implant. And then I lost the third one.
Yeah, no, that's fine. So the last part was, is there an age cutoff for you regarding MRI for knee pain patients with no concern of sinister pathology and primarily mechanical pain?
No. So again, saying no is a bit academic, isn't it? But I think that anybody who presents with an acute knee problem, that they can remember what they were doing. I have lots of patients who are in their 60s, 70s and early 80s who are either still working or doing things that are, meniscal tearing, generating activities, whether they're hill walking or whatever. And I think that every patient deserves to understand what's causing that and whether you can influence that, because particularly as you get older, every year of life's precious. So who am I to say that an 80-year-old doesn't warrant an MRI scan? Now, when you see that patient and examine that patient and get some plain radiographs, it might be very obvious that actually the main problem is an osteoarthritic profile. And the NHS sort of old person knee scope to try and buy a bit more time for a severely end-stage arthritic joint got very bad press, and that's the one that was in the BMJ saying that it's not worth it, etc., etc. And that's all about qualities, and that's all about health rationing. And it's quite true. If someone's got end-stage arthritis with a macerated meniscus, then that they'll get a subjective benefit from that surgery for maybe 3 months, 6 months, maybe even out to a year. But after that, their main problem is the arthritis. So it's a risk-benefit discussion.
Fantastic. You've got lots and lots of thank yous. There's just one more question from Kevin. Monitoring heavy metal levels post-hip replacement, for example, cobalt, is this needed? How high can we tolerate?
Yeah, so that's another good question. So anybody who's had a metal-on-metal articulation, the advice is that they should have annual metal ion measurement, particularly if they're symptomatic. Now, if they're non-symptomatic and their ion levels are low, then it can be stepped down, but that's quite a burden. And what you need to remember is that when they have that joint implanted, then they have a wear-in period. So there's a period, just like a car engine, where it's excessively wearing for the first couple of thousand miles. So in old days, people were told to drive easy for the first couple of months to wear the engine in. And that's exactly what was happening. So you're trying to get the metal on metal to wear in an appropriate fashion. After that, you tend to reach a more steady state wear phenomenon. So anybody who's presenting with a limp or pain around their arthroplasty or any sort of soft tissue fullness, they need to be sent in for urgent sectional imaging, usually a Mars MRI scan, looking for alval type lesions, adverse reaction to metal debris, and have their ions measured of cobalt and chromium. So every laboratory is different. And generally it's 7 and 5 parts per billion, but you don't worry about that. When you've done the test, it comes back with the laboratory reference range. And of course you can monitor. So just because someone's got a high ion level, if their sectional imaging is satisfactory, you can elect to maybe see them in 6 months or a year and see where that's going, whether it's troublesome. But a lot of patients with the press and the litigation that's going on, they don't really want to be told that these metal ions could well be sort of sitting in their filter system, in their lungs, in their kidneys, and even in their brain. They often just want rid of that problem. So it's a difficult one to negotiate, and that's why I'm not particularly prepared to put metal on metal into someone, because I don't want to be having these discussions in 10, 15 years time with them. Not when we have good alternatives.
Fantastic, thank you. So yeah, loads and loads more great feedback on there. So yeah, no more questions.
But just when you're doing that, you know, it's great to be able to to be able to do these sessions and to sort of try and get a feel for what the need is out there. I mean, everybody wants a bit of CPD, I get that, but it'd be quite nice to actually feel as if you're having something useful and something specific. So this was quite a generic one because I was thinking about COVID-19, and if there's an appetite in the future to visit something specific, I'd be very happy to talk about arthroplasty, for example, robotic surgery, anything. So I would suggest that maybe if you want to feed back through Harry, we can do shorter sessions or whatever, then we could organize another one that was specific to the general need. You got to remember, there's all this stuff about, you know, me sitting in my ivory tower with access to imaging and stuff. So I can only project and talk to my sister and my friends who are general practitioners and that sort of thing to try and understand what life is like the other end of the spectrum, as well as the the therapists, and it hasn't been easy. A lot of my patients now are talking about seeing therapists face to face and actually having hands-on, and a lot of people are trying to do sort of telephone and telemedicine type consultations, which are very difficult to effect. So I've no doubt that you've been feeling the burden as well, and believe you me, when this passes, or the floodgates get lifted a little bit more, it's not going to be much fun for any of us. So yeah, anything that we can do to join up thinking and to try and address common problems and help each other out as a two-way street, then that would be great. I'm aware that I'm getting darker and darker. I'm trying to find books that might help. That might work a bit. But anyway, were there any other questions, Harry? I can tell everybody's either hungry or wanting to go to bed soon. So
no, just more and more thank you. So yep.
Just make me look freaky.
And as Mr. Carrothers said, feel free to email me with any topics of interest that we can visit. And thanks again, everyone, for signing in. And we'll see you all again next week. I'm back on Tuesday. So if you haven't seen the programme, please do email me. Thank you very much. And thanks again, Mr. Carrothers.
You're very welcome. Have a good evening, everyone. And Harry, you're both looking and sounding more like Joe Wicks every day of the week.
Oh, I definitely haven't done one of his workouts.
All right, folks. Have a good evening. Thank you very much. Take care.
Thanks. Bye.
Bye-bye now.